The emergency call comes at 3:47 a.m. Detroit General Hospital needs O-negative blood immediately. A car accident, multiple victims, children fighting for their lives. Sugar Ray Robinson grabs his coat and races to the Red Cross Donation Center, only to have the head nurse look at his registration form and declare, "We don't mix blood types here." What happens in the next hour doesn't just save lives, it exposes the deadly absurdity of segregated medicine that places racial prejudice above human survival. Detroit's Red Cross Blood Center sits in a converted warehouse on Cass Avenue, fluorescent lights buzzing overhead, the smell of antiseptic mixing with coffee from the volunteer break room, metal folding chairs arranged in neat rows, medical equipment that could mean the difference between life and death for accident victims across the city. This is where Detroit residents come to give the gift of life, where your generosity gets measured not by your willingness to help, but by the color of your blood donor card. Robinson burst through the front door at 4:15 a.m., still in pajamas under his overcoat, having received the desperate phone call from Dr. Sarah Mitchell at Detroit General. 3 children from the same family, ages 6, 8, and 11, their parents dead on impact, all 3 requiring immediate transfusions, O-negative blood, the universal donor type that can save anyone's life when minutes matter more than anything else in the world. Head nurse Dorothy Whitman looks up from her paperwork with surprise and annoyance. 4:15 a.m. emergency donations aren't standard procedure. The center doesn't officially open until 8 a.m. But Dr. Mitchell's call was desperate. Children dying, blood supply critically low, every minute counting toward life or death outcomes. In Robinson's mind, this should be the simplest equation imaginable. Dying children need blood. He has the right blood type. Time equals life. But Detroit in 1959 operates by different mathematics. Mathematics where even life-saving medical procedures get filtered through racial segregation policies that prioritize social comfort over human survival. "Mr. Robinson," Whitman says, recognizing the famous boxer despite the early hour and casual clothing, "I appreciate your willingness to help, but we have specific protocols for blood collection and distribution." Can you imagine Robinson's confusion, racing to save children's lives, and being told about protocols when every second matters? "Protocols?" Robinson asks, pulling off his coat. "Dr. Mitchell called me directly, said 3 children are dying and need O-negative blood immediately. I'm O-negative. Let's do this." Whitman examines Robinson's previous donor records, multiple donations over the years, clean medical history, perfect blood type match for current emergency. But there's a complication that transcends medical necessity, a complication rooted in social policies that separate blood donations by race. "Mr. Robinson, your previous donations have been processed through our colored donor program. The current emergency requires blood for white recipients. We maintain separate processing protocols to ensure appropriate matching." Appropriate matching, the euphemism that makes racial segregation sound like medical necessity instead of social prejudice. Picture the crushing irony of this moment. Children dying while life-saving blood gets rejected based on the donor's race, not the blood's compatibility. Robinson stares at Whitman in disbelief. "You're telling me that my blood, which is medically identical to any other O-negative blood, can't save children's lives because I'm black?" The directness forces Whitman to confront the absurdity of segregated medicine. Usually emergency situations don't arise. Usually racial protocols remain invisible. Usually people don't challenge medical segregation when lives hang in the balance. "Sir, it's not about medical compatibility. It's about recipient preference and family comfort levels. Many families prefer blood from donors who share their racial background." Recipient preference, family comfort levels, the language that transforms life-saving medicine into social accommodation. But what Whitman doesn't realize is that she's not just denying blood donation, she's forcing Robinson to confront how deeply racial segregation penetrates American society, even in matters of life and death. The donation center phone rings urgently. Dr. Mitchell calling for updates on blood availability. Whitman answers, speaking in hushed tones about complications with donor protocols and processing procedures. Robinson overhears fragments of the conversation. "Understand the emergency, doctor, but we have policies." Can you feel the moral weight crushing down in that sterile room? Medical professionals debating social policies while children bleed to death? Robinson's patience snaps, not from anger but from moral clarity. "Nurse Whitman, let me ask you a direct question. If your child was dying and needed blood transfusion, would you care about the donor's race or the donor's blood type?" The question cuts through medical euphemisms like a scalpel, forcing Whitman to choose between theoretical racial preferences and actual parental instincts. "That's not the point." "That's exactly the point," Robinson interrupts. 3 children are dying right now. I have the blood type that can save them. Every minute we spend discussing racial protocols is a minute closer to their deaths. The moral authority of Robinson's argument creates pressure on Whitman's position. She's trained in medical procedures, not ethical debates about segregated medicine. But then the unexpected happens. Dr. Mitchell arrives at the donation center, personally, having left the hospital when blood procurement became critical. 42 years old, chief of pediatric surgery, 20 years of medical experience fighting to save children's lives. What's the delay? Mitchell demands, seeing Robinson ready to donate and Whitman still processing paperwork. I have 3 children in critical condition who need O-negative blood immediately. Whitman explains the racial protocol complications, donor matching policies, family preference considerations, administrative procedures that ensure appropriate blood distribution. Mitchell listens with growing incredulity. Nurse Whitman, are you seriously telling me that you're preventing blood donation while children die because of racial policies? The medical authority challenges administrative authority directly. Doctor versus nurse. Patient care versus procedural compliance. Doctor, we have established protocols. Protocols? Mitchell's voice rises with barely controlled fury. My protocols are saving lives. Your protocols are preventing me from saving lives. Which protocols matter more when children are bleeding to death? This is where everything changes, where medical mission meets administrative prejudice, where life-saving urgency confronts social segregation. Robinson steps into the confrontation. Doctor, I'm ready to donate. I understand the medical necessity. I don't understand the racial barrier. Mitchell turns to Whitman with professional authority. Nurse, I'm ordering this blood donation immediately. 3 children's lives depend on it. Any administrative concerns can be addressed after we save them. The medical order creates direct pressure on nursing compliance. Whitman facing choice between professional hierarchy and administrative policies. Can you imagine the tension crackling through that donation center? Life and death urgency meeting institutional racism? Doctor, Whitman responds carefully. Family members are present at the hospital. They may have preferences about blood donor characteristics. We should consult them before. Consult them. Mitchell interrupts with professional outrage. These children are unconscious and dying. Their parents are dead. I'm their attending physician, and I'm telling you they need this blood now. The medical authority eliminates family consultation arguments. Emergency medicine trumping social preferences. But Whitman tries one final administrative barrier. There are liability concerns, insurance complications, documentation requirements for cross-racial blood donations. Robinson reaches his breaking point, not with anger but with moral clarity that cuts through administrative excuses. Nurse Whitman, Robinson says, his voice carrying the authority of someone who has faced life and death moments in boxing rings. I'm going to ask you something. If you prevent this donation and those children die, will your paperwork bring them back? Will your protocols comfort their surviving relatives? Will your racial preferences matter to anyone except you? The questions echo through the donation center, like prayers seeking answers, forcing everyone present to confront the human cost of administrative prejudice. Mitchell supports Robinson's position. This is the most absurd medical situation I've encountered in 20 years. We have dying children, available blood, willing donor, and administrative barriers based on racial policies that have nothing to do with medicine. The combined pressure from medical authority and moral argument overwhelms Whitman's administrative resistance. She realizes she faces professional crisis, refuse the donation and face responsibility for children's deaths, or approve it and face administrative criticism for violating racial protocols. But community pressure begins building in Robinson's favor. Word spreads through Detroit's medical community about the blood donation crisis. Other healthcare professionals arrive at the donation center, offering support for emergency procedures. Dr. James Washington, head of surgery at Receiving Hospital, enters the donation center after hearing about the situation from Dr. Mitchell, 50 years old, one of Detroit's few prominent black physicians, expert at navigating medical segregation. What seems to be the problem here? Washington asks with professional authority. Mitchell explains the emergency situation. Dying children, available blood, racial barriers preventing donation. Washington examines the medical facts, blood type compatibility, emergency necessity, administrative obstacles, based on racial policies rather than medical requirements. Nurse Whitman, Washington says with quiet authority, I've practiced medicine in Detroit for 25 years. I've seen children die because of delayed treatment. I've seen families destroyed by preventable tragedies. Are you really going to let racial policies prevent life-saving treatment? The pressure from multiple medical professionals creates overwhelming moral authority supporting the donation, but Washington adds another layer of professional pressure. I'm also reporting this situation to the American Medical Association Ethics Committee. They need to examine how racial policies interfere with emergency medical care. The threat of professional oversight adds consequences to Whitman's decision, not just immediate emergency, but career implications of prioritizing racial policies over patient care. Whitman realizes she's fighting a battle she cannot win. Medical professionals united against administrative policies. Moral arguments supporting life-saving treatment. Professional oversight threatening career consequences. Very well, Whitman says finally. Under emergency medical protocols and physician orders, we'll proceed with the donation. The victory represents more than one emergency response. It represents proof that medical necessity can overcome administrative prejudice when healthcare professionals unite behind patient care. The donation proceeds quickly. Robinson's blood drawn expertly, processed immediately, rushed to Detroit General for transfusion. Within minutes, life-saving O-negative blood flows into 3 dying children. All 3 children survive. Their recovery validates every argument about medical necessity, transcending racial barriers. More importantly, their survival demonstrates that segregated medicine kills people when social prejudices override medical requirements. The incident spreads rapidly through Detroit's medical community. Doctors and nurses discussing how racial policies interfere with patient care. Medical students learning about ethics versus administration. Healthcare professionals questioning institutional barriers to life-saving treatment. Within weeks, Detroit's Red Cross changes blood donation policies, not because of changed hearts, but because medical professionals demand policies that support patient care rather than social segregation. Other blood centers across Michigan hear about the Detroit changes. Progressive medical facilities begin eliminating racial barriers to blood donation. Conservative facilities cannot defend policies that prioritize social comfort over life-saving treatment. The Robinson incident becomes case study in medical schools. How to handle conflicts between institutional policies and medical ethics. How to apply patient care principles when administrative barriers threaten treatment. Harvard Medical School includes it in their ethics curriculum. Johns Hopkins uses it in discussions about healthcare access. University of Michigan makes it required reading for medical students. Medical conferences across the country begin featuring sessions about segregated healthcare. The American Medical Association hosts panels on racial barriers to treatment. The National Association of Colored Physicians shares the Robinson story as example of medical advocacy. Progressive medical organizations use it as evidence supporting healthcare integration. The 3 children Robinson's blood saved grow up healthy and strong. Their survival becomes living testimony to the importance of medical necessity over racial preference. Years later, when they learn the story of their survival, they become advocates for integrated healthcare. Dr. Mitchell and Dr. Washington become lifelong allies in fighting medical segregation. They co-author papers about emergency care protocols. They testify before medical boards about racist policies. They train young doctors to prioritize patient care over institutional comfort. Nurse Whitman never admits her policies were wrong, but she never again prevents blood donations based on racial criteria. The memory of nearly letting children die haunts her professional conscience. Every emergency case becomes a reminder of the day she almost chose protocol over patient survival. National medical journals publish extensive coverage about segregated blood donation. The Journal of the American Medical Association runs editorial series about race versus medical necessity. Medical Ethics Quarterly publishes special issue discussing professional obligations when policies conflict with patient care. The New England Journal of Medicine features Robinson's case in landmark article about healthcare integration. Robinson's blood donation saves more than 3 children's lives. It exposes how deeply segregation penetrates American medicine, how racial policies create deadly barriers to life-saving treatment, how healthcare professionals must choose between institutional compliance and medical ethics when lives hang in the balance. The incident influences medical civil rights strategies nationwide. Instead of attacking healthcare institutions through protests, reformers begin using medical necessity arguments to challenge discriminatory policies. Clinical evidence supporting integration, professional ethics demanding equal treatment. Blood banks across America review their donation policies after hearing about Detroit. Southern facilities face particular pressure to justify racial barriers to life-saving donations. Northern hospitals begin advertising integrated medical services as competitive advantages. Progressive medical centers recruit minority healthcare professionals to demonstrate commitment to equal treatment. Robinson understood something powerful that morning at the blood center. Sometimes the most important fights aren't in boxing rings or political forums. They're in medical settings where institutional policies can literally mean the difference between life and death for innocent people. The victory wasn't just about blood donation procedures. It was about proving that medical science recognizes no racial boundaries, that life-saving treatment must be available to everyone regardless of social prejudices that have nothing to do with clinical reality. Think about healthcare policies in your community. Medical institutions that claim to serve all patients while maintaining barriers based on demographics rather than medical need. Administrative procedures that prioritize institutional comfort over patient care when lives are at stake. Because 1 hour of medical moral clarity can change healthcare policies forever. can prove that patient care transcends social prejudices completely, can demonstrate that life-saving treatment is fundamental human right, that no administrative barrier should ever compromise. Robinson didn't just donate blood that morning. He proved that medical necessity defeats racial prejudice when healthcare professionals unite behind patient care principles, that saving lives matters infinitely more than saving social comfort, that medical ethics properly applied recognizes only patients in need, not racial categories designed to limit treatment access.